All right. Thanks, everyone. So kind of in our impromptu bone and soft tissue June, Peter and I have decided to split up the sessions in alternating me, him. Some of it's going to be pattern based and some of it might be just tissue of origin based. And some of it might be overlapping, but you know, repetition I think is good. So my approach, and please give me feedback on this after the session, is to combine some unknown, like a bunch of unknown slides with didactic, like PowerPoint slides, so that we can have both a didactic and an unknown session at the same time. So I sent you guys the link for the ones that just have the slides. Mine have the PowerPoints in it with like the key points, but I'll send that out also so that you can have the full version with the PowerPoint slides embedded in it. Sound good?
Yep.
Okay, so here we go. Sorry we started late. Sorry for the technical difficulties. So pretty much there were no, I didn't really give you any histories because a lot of the time I want to talk about the kind of history and setting in the context of the case. So anybody who perhaps is, I'm going to ask you guys to talk. So,
sure.
You know, anybody maybe who is more junior or want to just sort of describe what we see in this slide, at least where are we, first of all?
That's probably the most important part.
Let's practice looking at normal. Who's on? Heather.
Yes.
Smith.
Me.
What are we looking at?
We're looking at muscle.
We're looking at muscle. What kind of muscle?
It looks like skeletal muscle. The nuclei are kind of at the edges.
Yes, so thick pink syncytia with nuclei marginated to the edges. Maybe you could see a few kind of striated-like lines there. All right, so skeletal muscle. And then we have this lesion in, around, next to, and amongst the skeletal muscle. So overall, I mean, I think you know what the session is going to be talking about, right? So overall, what's the general pattern of this lesion?
It's loose, cobwebby, and kind of myxoidy.
Kind of myxoidy, right? So for those of you who don't already have it, I highly recommend you get that. Oh, here it is, this one, the Hornick book. Can you see this one, the Practical Soft Tissue Pathology? It goes very much into patterns, right? So it's like there's a myxoid chapter, right? So this is like when you're not like, oh, I have a great differential, let me go look up each one of those entities. It's like, well, I can tell that this is myxoid. It will tell you the differential, right? So that's why I like this book a lot. Yes, highly recommend. So what do you think the cells here are quite bland or quite pleomorphic?
They're very bland.
They're very bland. And do you think the edge is quite circumscribed or quite infiltrative?
It's super circumscribed.
Great. So with spindle cell lesions, right, with any lesion, we always want to look at the border and we always want to look at the sort of morphology of the spindle cells, the morphology of the stroma, and the relative atypia of the spindle cells. So here we have a myxoid, very pale, wispy background with maybe strands of pink collagen, maybe here and there. I'm going to use my fun annotations. Maybe here and there, there's like a slightly enlarged nucleus, but really, you know, all of the nuclei in the background are oval to elongated. They're not really cigar shaped, right? Like when you say cigar shaped, what does that kind of imply?
Like muscle cells.
Like a smooth muscle cell, right? When you say wavy or pointed ends, what does that imply?
Nervy stuff.
Nervy stuff. When you say kind of a stellate-shaped nucleus or a stellate-shaped cell, what that might imply?
Like fibroblasty kind of
stuff? Kind of a fibroblast or a myofibroblast, exactly. So these are a little bit plump. Maybe they have small points at the ends. They have very wispy cytoplasm. So we're probably dealing with some kind of fibroblast, myofibroblast. And it is bland, it is well circumscribed, and it is in muscle. So what's the diagnosis?
Like a myxoma?
Like a myxoma. So there's lots of types of myxomas, including intramuscular, right, which is what we see here, juxta-articular, next to the knee, and they all should present this very bland histomorphology without many vessels, Sometimes they stain for a little SMA, meaning a myofibroblastic lineage, sometimes a little CD34. So CD34 not only stains endothelium, right, but stains fibrocytes sometimes. So CD34 SMA are kind of these fibroblast, myofibroblast markers. There are some cases that have mutations in GNAS gene. And for those of you boards takers, right, always syndromes come up. So Mazabrod is intramuscular myxoma with fibrous dysplasia of bone. So this was an example of an intramuscular myxoma. Just to reemphasize, you know, pretty evenly cellular. Sometimes it can get a little more cellular, especially in the syndromic cases, but really minimal vascularity. Okay, because this is going to be important for the other myxoid lesions that have increased vascularity. We'll talk about those as we go. All right, so the next one. The repeating pattern of kind of this smudgy, pale bluish to pinkish myxoid material. But in this myxoid material, are there actually cells? Are there many nuclei like we saw before? Not really. There's one here, one here, one here, one here, but not really as many nuclei, right? However, what do you see that's different about this one? Is it a single thing or is it multiple things?
It's not as well circumscribed, almost poorly circumscribed.
And there are multiple kind of spaces, right?
Yeah.
And is there anything at the edge of the spaces?
Oh, they're lined by single cells.
I was hard pressed to find any epithelial lining.
I think I heard someone talking extremely faintly, by the way. Whoever just spoke before Imran, you're very quiet.
Oh,
It's
those are-
Faiza.
Oh. All right, so not a significantly present epithelial or, for that matter, endothelial lining, maybe a few cells lined up at the periphery. Present in, what are we in? Are we in skeletal muscle? Are we in fat? What are we in now? Always look at where you are.
Very dense fibrous tissue.
Yeah.
We're in dense
Like
fibrous
fibrous,
tissue, right? So
yeah.
here it's not discrete band. I know that people sometimes get mixed up with like fascia, tendon, fibrous tissue, and skeletal muscle, right? So burn this in your brain. These fascial things are they have wavy like lines of collagen. They don't have discrete fascicles. The nuclei are like compressed by those wavy fibrous bundles, and they're kind of scattered throughout. So this is, you know, fibrous tissue, tendon, ligament. This is what you might see in a fascial plane or around a joint. So anybody want to offer up a diagnosis for this?
Ganglion cyst.
Ganglion cyst, right? So these are, you know, myxomas, ganglion cysts, these are bread and butter things that you're going to see. It's important to just be able to identify what they are, right? So sometimes ganglion cysts don't actually have a cystic space. Sometimes they're just myxoid connective tissue degeneration like we see here, right? So this can almost look like a myxoma, right? But usually the clinical history is near a small joint rather than deep within the muscle, right, of the thigh. And often, but not always, you see some kind of pseudocystic lining with pseudocystic space rather with no lining, with myxoid stuff in the middle. Sometimes the kind of lining that you'll see is what?
You can sometimes see macrophages lining them, kind of.
Okay, so macrophages or modified macrophages near a joint is what?
Synovial cells.
Synovium, right? So sometimes ganglion and synovial cyst get lumped together or separated depending on the person or the pathologist. I don't know. I think they're the same because sometimes the cyst lining is denuded and you call it ganglion. Sometimes the cyst lining has synovium and you call it a synovial cyst. I think it's all the same. They're all near joints. They're all myxoid connective tissue degeneration, leakage of fluid. So I don't really care either way what you call it. Questions on that one?
Much more of an intact resection than I usually see for ganglion cysts.
Right. So, and even ink. So it must have been called like a mass or something, and they shelled it out and somebody inked it. Now, a lot of these I found on Path Presenter on the just on their public cases. Some of them I uploaded myself. So if you guys haven't checked out this website, it's pretty awesome. All right, here's another one.
So
Somebody tell me where we are.
very interesting site.
Yeah. So you already, we're in lung, right? So we already have a couple differentials, like is this a metastasis or is this primary? Because, you know, you could have primary soft tissue lesions in the lung. Don't, you know, exclude that. However, once we make a diagnosis of this, we'll see why it is what it is. All right. So again, myxoid background. Already, what's the difference between those other two lesions that we saw?
Well, there are these.
Vessels and fats, cells. Sorry.
Yeah.
Somebody said, Christina, sort of chicken wire, and somebody I think said vessels. Exactly, right? So I think you can see my annotations. Already, they're small, right? They're small vessels, but this thing is richly vascular and somewhat higher cellularity. Exactly. So always look at the stroma, right? The circumscription, the vascularity, the morphology of the cells. And so the morphology of the cells here is, again, kind of wispy, right? So wispy, stringy cytoplasm with sometimes ovoid, sometimes triangulate nuclei. But what are the things that keep popping up?
Fat cells.
Fat cells. What's the shape, or how would you describe these fat cells?
The different shapes and sizes.
Mm-hmm.
So.
They're different shapes and sizes, and they have vacuoles, yeah?
Yeah.
And so how do you want to call these cells? Are they just mature fat?
No.
What are they? They could be pseudolipoblasts. They could be real lipoblast. Okay, so how do we tell the difference? So real lipoblasts have clear vacuoles that indent the nucleus, okay? So see how these nuclei are being compressed into these hourglass shapes by the
Green, Dr. Cipriani.
Yeah, I'll just chime in. For some reason, the screen share, it's all greened out except for where you're drawing. If you could like minimize and re-maximize the window, that might fix it. Like we see green. There we go. Yeah, fix it.
Weird. So when I try to annotate, it just shows.
Why don't you try it again and see if it does it again?
Hold on.
Oh, I thought that was
I mean,
by
you-
design, just to
you were-
focus on specific areas.
You were annotating earlier just fine, and it looks fine now. It's just when you did, oh, there it goes again. It just
Yep.
grayed out. Like the whole screen turns green except for where you're drawing. Then there it renders properly. It's a little whack.
Weird. Is it green still?
It's still the
Yeah.
background, except for the lipoblast. We figured you were just like green screening and then like uncoloring the areas of interest.
Weird. All right, I'm going to try a different. I'm just going to share the whole screen one and see if that makes a difference. All right. Tell me if this changes. So
Nope, no green screen. We're good.
we're good?
Mm-hmm.
Okay, great. Maybe it was dependent on what I was sharing, because I was only sharing the application window. I wasn't sharing the whole screen. That shouldn't
Oh yeah,
matter.
that'll do it. Yeah, like
That do
if
it?
somebody's sharing their screen and they have a box on the screen, it'll just gray it out.
Oh, all right. So this worked?
That worked.
Okay, cool. So right. So lipoblasts have vacuoles, either single. If it's a single vacuole, how do we designate these? I don't want to give you the finger, but right. Signet ring, right? So a signet ring lipoblast has the nucleus compressed at the edge and a vacuole, like those rings they sell in colleges, yeah? But a multivacuolated lipoblast has indentation on multiple sides, and the nucleus is kind of squashed in the middle. So those are suggestive of potentially real lipoblast, okay? Not brown fat, potentially not pseudolipoblasts. Pseudolipoblasts may have more plump nuclei that are not necessarily fully indented and are not necessarily kind of hyperchromatic. So we have a myxoid background with sort of moderate cellularity, with lipoblasts, and with nuclei in the background that, are they super pleomorphic or are they sort of still kind of bland-ish? Where on the spectrum of pleomorphism would you put these background cells?
Mostly bland.
Mostly bland, right? So if you start seeing excess pleomorphism in this setting, your differential diagnosis changes. However, with bland, relatively blandness, with myxoid, with vascular, with lipoblasts, what's the diagnosis?
Myxoid liposarcoma.
Myxoid liposarc, right? So what age are we usually dealing with, and what site?
Well, it's young-ish patients on the range of like 20 to maybe 50 is what I've seen.
Yeah.
The usual primary site is not here, because the reason we're in lung is that lung is the most common site of sarcomal metastasis, but usually it's in the thigh.
Extremity, thigh, exactly. So young adults, 20s, 30s, 40s, extremities, trunk. So if it is ever outside that location, it is a metastasis. So, right, as Tim was saying, the lung is the most common site of metastasis for sarcomas. But if you see anything that looks like a myxoid liposarcoma outside of the trunk or extremity, sort of by definition, it is a metastasis. And we're going to see why perhaps in the next slide. So this is in the retroperitoneum. And first I'm going to go look at this area. And you might think, same diagnosis, different diagnosis. What do you guys think? So what does it have? It has the myxoid background. Yeah. It has curvilinear vessels.
Mm-hmm.
It has somewhat blandish, not super pleomorphic cells. The vascularity is arguably still present. Perhaps it's a little bit obscured, but I think, I think the vessels are still there. What else? Do we see good lipoblasts?
I did not on my first pass.
Yeah, so lipoblasts are a little bit more harder to see here. Sometimes a myxoid liposarc can be lipoblasts poor. However, do you think this looks kind of similar to what we saw of myxoid? Kind of similar without the lipoblast, but we're in the retroperitoneum.
The cytology is similar, and the kind of stromal, the stromal background is similar, sure.
Exactly. But there's really no good lipoblasts, and I'm telling you we're in the retroperitoneum. So in this case, now we're going to look out here. In this case, what is our revised diagnosis?
Be de-differentiating.
Somebody said de-differentiated. De-differentiated what?
Oh, liposarcoma.
Liposarcoma. Looks more like mature fat. Yes, so out here, this is mature fat. These are not lipoblasts. And what we do see in the mature fat are these hyperchromatic, arguably kind of triangular or angulated cells, which will allow us to make a diagnosis of liposarcoma, right? However, it's no longer myxoid liposarcoma. It is the well-diff-D-diff spectrum. So let's talk about the well-diff-D-diff spectrum. So anytime you see something in the retroperitoneum, it is either, if it looks like myxoid liposarc, it could be a metastasis of myxoid liposarc to the retroperitoneum. If it looks like this, it is on the well-diff-D-diff spectrum of liposarc. And so what do you need to make something from well-diff to D-diff? I'm giving you the answer on the slide, okay? So remember, there are 3 buckets of liposarc. There's atypical lipomatous tumor well-diff D-diff spectrum, which are grouped by their problems with chromosome 12. There's myxoid round cell that are grouped by the CHOP-FUS translocation. And there's pleomorphic, which is just complex and ugly liposarc, okay? So to go from well-diff to D-diff, you need essentially hypercellularity and mitotic activity, exactly. So mitoses and cellularity are important. Let's launch this guy. I don't know why I just did that, sorry. Can you see that again?
Yes.
Okay,
So your slides are actually built into Path Presenter then?
Yes. You
Oh,
can
cool.
upload PowerPoint slides and drag them and rearrange them so that it's seamless between the unknown slides and your PowerPoints.
Nice.
It's pretty cool. All right. So in the prior example of the retroperitoneum, I think Peter probably will tell you more about fat. Does this area have hypercellularity and increased mitoses? Certainly not hypercellularity. I think I saw a mitosis here and there, and people are saying not really. Not really, okay? So you have classic lipomatous, well-differentiated liposarc over here, and you have myxoid liposarcoma like well-diff liposarc on the left, okay? So morphology of well-diff liposarc can be variable from adipocytic to myxoid, etc. So don't call this D-diff because it doesn't have the hypercellularity and mitoses, but it's still well-diff in the retroperitoneum, all right? So remember your very, very discrete cutoffs for each of these sort of boxes. You can prove them all by genetics. The only thing you can't prove by genetics is pleomorphic liposarc, which is a disease of the elderly, usually on the extremities. So if it doesn't have chop fuzz or it doesn't have MDM2 amplification, but it looks like that, then you can call it pleomorphic, okay? Essentially. Does anybody have questions on this? I'll give you guys this so you'll have it. Okay. All right. So now the next one.
Yeah.
So we have skin up top, so we know where we are, and then we have this in the subcutaneous fat. So I'm not gonna make you tell me that it's myxoid because I think we know where we're going with this.
Immediate feature that jumps out at us is the very extreme and bizarre atypia. You know, you have a lot of large atypical mitoses, nuclear pleomorphism with size variation of like 1 to 20. This is something that when I look at this, the first thing that comes to mind, especially in the subcutaneous location, I would think about like atypical fibroxanthoma and that differential. I guess okay. I'm reminded from your slide just now that there is also pleomorphic liposarcoma that can have extreme bizarre nuclear atypia, but I'll be honest with you, the myxoid stroma is not a feature that I specifically associate with either of those two entities.
Exactly. So so the two entities you said were atypical fibroxanthoma, which, can you explain to me what atypical fibroxanthoma is?
Yeah, I always struggle with the cell of origin is, but it's
nobody cares about the cell of origin. We only care about what it looks like now.
Right. So it has, as we sort of discussed, extreme nuclear pleomorphism. It tends to occur in, I believe, more sun-exposed areas of skin. If I recall correctly, there's not a distinctive immunophenotype to it. You mostly use IHC to include other entities.
Okay.
What else to say about it?
Okay, good. So atypical fibroxanthoma is basically a high-grade sarcoma of the dermis in sun-exposed sites. So we're too deep for that, first of all.
Right.
But yes, it's a highly pleomorphic spindle cell sarcoma in the dermis, usually of elderly adults. That's either, it's related to sun-induced damage. Whether it's a spindle cell sarcomatoid carcinoma or a true sarcoma, don't really know. But okay, so we're a little too deep for that. But we do have appropriate myxoidy, we do have appropriate pleomorphism, right? Arguably this doesn't have pleomorphic lipoblast, right? It doesn't have the vacuolated cytoplasm with the indented nuclei, but it does have significantly pleomorphic cells with myxoid stroma, and it is highly infiltrative, right? Highly infiltrative with multiple nodules in fat, in subcutis. So anybody else want to throw out another diagnosis? The next slide is the same diagnosis.
Myxofibrosarcoma.
Myxofibrosarcoma. Okay, so myxofibrosarcoma. Tell me what are the key points of myxofibrosarcoma clinically to pathologically?
Clinically, they tend to present on the extremities, and they tend to be like subcutaneous as well.
Mm-hmm. Young or old?
Oh, a lot older.
Mm-hmm.
A lot older. They don't have any specific like other like key immunohistochemical markers or genetic abnormalities, like specific abnormalities that we know of.
Mm-hmm.
Kind of this multinodular growth to them histologically.
Mm-hmm.
There's kind of a spectrum of cellularity and atypia between low grade, high grade.
Right. Right.
Yeah.
Excellent. So trunk and extremities, older people, subcutis, highly infiltrative, highly myxoid, highly vascular, and highly pleomorphic. So this amount of pleomorphism you should not see in a myxoid liposarc, okay? So once you start seeing this amount of pleomorphism, think myxofibrosarcoma. It's because these are essentially fibroblast, myofibroblast morphology. Again, no specific immunomarkers, but maybe a little SMA here and there or CD34, and no specific genetics. These are basically high-grade sarcomas, or can be high-grade sarcomas with myxoid stroma. You can see here they track in the subcutis and they track peripherally along fascial planes, and they can be very hard to excise and therefore have increasing risk for recurrence. The one thing I did want to, we will talk about this. I forgot to put it in the presentation, but myxofibrosarcoma and many other sarcomas, right, are, why is this? I don't like that weird background. Here it is. Myxofibrosarcomas and other sarcomas are graded along the French system, right? So this is in our synoptic reporting for sarcomas, and it's in the WHO, it's in a lot of resources, right? But basically we grade sarcomas according to tumor differentiation, mitotic index, and necrosis. Each of them get a point and we add it up. So for treatment purposes, anything that's a grade 1 or a grade 2, so up to 5 points in this system, is high grade. Excuse me, grade, I'm mixing myself up. Grade 1 only is considered low grade. Grade 2 to 3, so 4 to 8 points, is considered high grade. So even though it's low, intermediate, high, or grade 1, 2, 3, technically for treatments, 2 and 3 are lumped together as sort of biologically high grade, and they will usually treat, so I say high, parentheses 2 of 3, or high parentheses 3 of 3 to clarify what we mean. So you grade myxofibrosarcomas along this French system. It can end up 1, it can end up 2, and it can end up 3. Okay? Okay. This is important because of what we're going to see coming up in the next few slides. All right, so this is a bit more challenging. I gave you a biopsy because this is what you're going to see, right? You're not going to, the diagnoses of soft tissue sarcomas is usually made on a core biopsy. And for educational purposes, it's really nice to see big sections, right? But when you're in practice, this is the important part. And this is what you have to make the diagnosis on. The resection comes later, and you may or may not end up revising the biopsy diagnosis, right? But the biopsy diagnosis is crucial. So let's practice making this diagnosis, making a diagnosis on this core biopsy. So does anybody want to describe it? Cellularity, low, moderate, high.
I'll say moderate to high cellularity. When I was looking at this case earlier, there actually wasn't, I felt like there weren't a lot of distinctive histomorphologic features to help us. We're in the sort of fibrocollagenous background.
Mm-hmm.
We have these sort of spindled to somewhat stellate looking cells without overwhelming nuclear atypia. There are vessels here which don't have a staghorn appearance. There's some extravasated reds there. One thing that I did notice is that I kept seeing all these clear little refractile like round things. I think that might have been an artifact, but I started seeing those absolutely everywhere on this scan slide.
Okay.
So as far as my differential, just based on that description, without finding any other distinctive areas, I didn't see heterologous elements. I didn't see anything necrotic. All we're sort of left with is the character of the nuclei and the stroma, which is especially pale here. I guess I would consider, based on our discussion earlier, we talked about how the shapes of the nuclei can sort of influence where we put this in our differential. I guess we'd have to consider, more fibroblastic lesions. I would consider neural lesions as well. Here, it kind of takes on more of a story form pattern, doesn't it? So maybe I'll start thinking about like a perineurioma.
Okay.
But in summary, I'm sort of stuck. I can't really get too far with just this so far.
All right. Anybody else want to throw out a differential in the comment or out loud?
I guess I'd want to know a little bit more about the patient too. Look at imaging, where they biopsying in this site, because if this is coming from, abdominal cavity versus extremity or something like that, it might focus your differential a little bit more.
Okay, so extremity, circumscribed, let's say, 6 centimeter mass in a 32-year-old, not associated with a nerve.
Not so.
Differential could include low-grade fibromyxoid.
You could either potentially consider even like a myxoid nodular fasciitis, though the nuclei of the cells are not the greatest for it.
All right, excellent. So how I'm going to describe this is I'm going to argue a little bit with whoever guys said highly cellular, because to me, when I think of a really cellular sarcoma, like the nuclei are back to back, right? There's hardly any intervening stroma. So I would say at most in this area, it's sort of moderately cellular. And I would say in other areas that it's somewhat more paucicellular. I would argue that the background has this eosinophilic collagen, right? And it has, where'd that other area go? Yup, and it has a little more pale, bluish, right, myxoid background, all right? I agree with you guys that the cells are kind of stellate in shape, kind of wispy. So perhaps fibroblast, myofibroblast differentiation. So maybe when you were saying cell of origin, that's what you meant. I would rather say differentiation, right? Because cell of origin is like, is this coming from a fibroblast? I'm more saying this is differentiating to look like a fibroblast, because all sarcomas probably come from mesenchymal stem cells, right? So cell of origin is a mesenchymal stem cell. It's more cell appearance of differentiation, just to clarify that concept. So for a nerve sheath tumor, like a derivation of Schwann cells, what's the immunostain you want?
S100.
Schwann cell, S100, SOX10. Okay. Perineurial cell, what do you want?
EMA.
All right. EMA, what else?
Gluten, Claudin 4, or Claudin 1.
Okay. We only have GLUT, so all right. S100, SOX10 for Schwann cells. EMA, GLUT1 for perineurial cells. What else did you guys say? Fibroblast, myofibroblast, right? So maybe and
D34.
What else? What was the other one we talked about? Myoid?
SMA.
SMA, all right, so I'm typing that in the comments. So the other differentials you guys had were, you said nodular fasciitis, you said low-grade fibromyxoid sarcoma. How are we gonna differentiate those? Because I think those are all very, very good. And immunostains in this particular case are going to be helpful. So what would nodular fasciitis stain for? Is it a fibroblast, myofibroblast? So Desmond or SMA, right? So some kind of myoid thing. What would low-grade fibromyxoid sarcoma stain like?
EMA.
EMA. We've already got that on our list. What's the one other stain we want to add?
MUC4.
MUC4. Okay. So for all of you who are confused, hopefully we can clarify this, all right? So this is the problem with bland, paucy to moderately cellular soft tissue lesions, is that we have a differential spectrum from benign to malignant, right? So we've shouted out nodular fasciitis, nerve sheath tumor, low-grade fibromyxoid sarcoma. Hopefully no one thinks this is a high-grade sarcoma, okay? But all of those are honestly appropriately for the differential. Did I give you, okay. This is the diagnostic immunostain. Who wants to vote what it is, or who knows already what it is, because you know this case.
Sort of hard pressed to actually describe the pattern of this immunostain. It's
Is it
is it like
nuclear,
nuclear,
cytoplasmic, or
perinuclear?
membranous?
It's not membranous.
Cytoplasmic?
All right, it's kind of cytoplasmic. The nuclei are arguably not staining, right? And it's not really a big crayon at the border of the cell, kind of, so cytoplasmic, okay.
They're like perinuclear.
So it's not S100 and it's not SOX10, because SOX10 should be nuclear and S100 should be nuclear and cytoplasmic.
Is this the MUC4?
This is a MUC4, okay. So this is a low-grade fibromyxoid sarcoma. So I'm showing you on, really?
So I will admit that when I was looking at the H&E, I was hoping that staghorn vessels would hand me the diagnosis. So I guess.
So why do you say staghorn vessels?
Well, first let me look at expert path and make sure I'm not conflating entities here. But I thought that you had these sort of slender and branching vessels in LGFMS.
So low-grade fibromyxoid sarcoma has no specifically characteristic vascular pattern.
Oh yeah, excuse me. I think I'm conflating.
You're conflating it with solitary fibrous tumor.
Yeah, that's probably it.
So it doesn't necessarily be described as chicken wire. It doesn't necessarily be described as thin-walled, dilated, branching staghorn. It's got some vessels in the background, right? So this is a full face section of a low-grade fibromyxoid sarcoma. So a low-grade fibromyxoid sarcoma is essentially by definition low histologic grade. If you did the French grading system, it would essentially always meet it because it has very few mitoses and really should have no necrosis. It has variable kind of fibroblast appearing cells in a collagenous background, to fibroblast appearing cells in a pale myxoid background, often kind of juxtaposed right next to each other. And you can see here a myxoid nodule. You can see here another myxoid nodule with sort of lesser myxoid areas interspersed in between. So the difference here is low-grade fibromyxoid sarcoma is essentially a tumor of young adults on the extremities or trunk, is defined by that sort of low to moderate cellularity with myxoid and collagenous zones, minimal nuclear atypia, and positivity for both MUC4 and EMA, and is defined by this FUS-CREB fusion. So thankfully, we have a way to isolate this low-grade sarcoma from all of the other benign things, and the potentially higher grade myxofibrosarcoma, right, which we just saw, which theoretically should be more present on elderly people, should have nice curvilinear blood vessels, should have more background cytologic atypia with those atypical pleomorphic cells that are often condensed along the sides of the vessels, okay? So I put this chart here because I think we've taught you guys, so the seniors, right, have had this pounded into their heads for years, like low-grade fibromyxoid sarcoma is different from myxofibrosarcoma. So, hopefully this has become known. Other names for LGFMS were Evans tumor, hyalinizing spindle cell tumor with giant rosettes, because some of them have these collagen rosettes, not all of them. Do I have another slide? Yes, okay. So here's a collagen rosette at the bottom left with a central collagenous core and cells palisading at the periphery. This is in comparison to myxofibrosarc, right, with these vessels, with these super pleomorphic cells in the background, very dark, very annulated, very hyperchromatic. Here, they're kind of squashed by the collagen, but they're otherwise very monotonous in shape and size, okay? Questions, comments, thoughts? Otherwise, we're gonna move
Is it
on.
worth on a biopsy to tease out sclerosing epithelioid fibrosarcoma, or is that not really that necessary? Is that going to alter their management?
It might. So the idea of sclerosing epithelioid fibrosarc, I didn't put it in here because it doesn't tend to have a myxoid background, but sclerosing epithelioid fibrosarc is essentially what? The high-grade version of low-grade fibromyxoid sarcoma. Yes? So it has collagenous but not really myxoid background. It has plump epithelioid cells in that collagen that sometimes line up in single file, like lobular breast cancer, and it stains for EMA MUC4, right? So it is in many ways very genetically and genetically and immunohistochemically similar to low-grade fibromyxoid sarcoma, but the cells are plump. You probably are going to see more mitoses, and that is considered to be the high-grade counterpart of low-grade fibromyxoid sarcoma. So they probably will treat it. They may treat it differently. Does that help?
Yes.
So
Does the
genetic,
low-grade
what?
Does the low-grade transform into the
It
sclerosing?
can. It can.
Do you ever see them juxtaposed to each other?
Yes. Yes. So they can be, so you can see low-grade on its own, LGFMS on its own. You can see sclerosing epithelioid fibrosarc on its own. And you can see them as a transformation.
Okay.
Yes. All are possible. But the morphology, you should see a morphologic shift. So we didn't talk about this with myxoid liposarc, right? But the high-grade counterpart of myxoid liposarc is round cell, just like the high-grade counterpart of well-diff is D-diff, right? So you can see myxoid on its own, you can see round cell on its own, and you can see a transformation. Same here. All right, other questions? All right, next case. It is myxoid, yes. Is it vascular?
It has vasculature.
It has vessels, okay. Is it infiltrative or circumscribed?
Just based on this field.
Yes.
Infiltrative.
At least a little bit infiltrative into fat. Yes,
Yeah.
okay, good. All right. And hypercellular, hypocellular, variably cellular?
It's on average more cellular than our LGFMS, so I'll say, moderate to high cellularity. Well,
Getting a lot of
variable is
on
actually
the
probably a
right,
better way for
on
it.
the right a little
Variable.
hypo, and then on the left a little
Yes, yes, yes.
cellular.
Variably cellular, okay. All right. Let's look at the morphology of the cells. So, are they blunt like smooth muscle? Are they wavy like nerve sheath? Or are they kind of open chromatin with small pinpoint nucleoli, or wispy like we think about myofibroblasts?
I think your description of open with pinpoint nucleoli is very apt. I think the nuclear shape is generally kind of ovoid.
Exactly. Okay, excellent. So what is the one thing now that we see quite abundantly? At least I'm seeing them everywhere.
Oh, the lymphocytes?
I don't know about you guys. Chime in, boys chat. So there are small lymphocytes, but what am I circling?
Mites.
Mites? Mitosis?
Mites, yeah. So they have they're a little hard to see, but they have little fingers, yeah? All right, so we have an infiltrative lesion that is variably cellular, of kind of wispy myofibroblasty appearance, with myxoid background, with vascularity, with mitoses. There's a nice one right there. What is it? Or what other features do we see? We see extravasated red blood cells. Okay. We see some wispy collagen.
Ooh. Has some rather large, more atypical cells that almost have like a virus site, almost like appearance to them.
Okay, so there's an occasional, yep, larger cell here, but it kind of looks maybe multinucleated, a little multinucleated. Is it a young person and is it painful? It could be a young or old person, and it may not necessarily have been painful. What are you thinking with that?
Nodular fasciitis.
So nodular fasciitis, what is the clinical progression of nodular fasciitis that is probably more key to, or relatively key to think about? So what's the one question you haven't asked?
Rapidly growing.
Rapidly growing, okay. So how long has this been present? 5 years? 5 days? A few weeks? Okay, yes. So nodular fasciitis is always on the differential of a spindle cell lesion, and you always have to think about it because it can be tricky, but you can give the person a benign diagnosis, and that's at least what this is claiming to be based on the path presenter slide. I don't know, I think these multinucleated cells may just be multinucleated histiocytes because they kind of have very monotonous multinucleated multiple nuclei with, again, little nucleoli in a cluster. So I think these might just be giant cells rather than the any other tumor type giant cell, because I know you were thinking about the sarcoma with virucyte-like cells. But things this has otherwise are a variation from myxoid to somewhat more cellular, like over here, right, with more collagen as opposed to myxoid stroma. Extravasated red cells, great for nodular fasciitis. Many mitoses, also great for nodular fasciitis. So if you're concerned about nodular fasciitis, how are you going to prove it? Is it a tumor? Is it not a tumor? Can you do something to prove it? Right, so it can be infiltrative. Genetics. Okay, so what are the genetics you want to do?
FISH, I think, is usually the way they do it. The USP6 my H.
Yeah. So, all right, USP6, exactly. They probe for the USP6 rearrangement. So be careful, because nodular fasciitis can be cellular. Nodular fasciitis can be infiltrative. Nodular fasciitis can be mitotically active, okay? But you can prove that it's a benign thing by doing USP6 gene rearrangement. I think this is perhaps another example, at least on that path presenter called nodular fasciitis. It is highly infiltrative. It's a little less myxoid. It's more of the cellular fibroblast type of morphology. So I'll let you look at that on your own. But here, so the things you want to remember about nodular fasciitis are those myxoid, sometimes microcystic areas, the wispy fibroblasts, the extravasated red cells, sometimes keloid-like collagen, which we didn't really see, but also these plumper, more cellular fibroblast-like areas, because these are myofibroblast differentiation. They usually have smooth muscle actin, and they should have USP6 gene rearrangement. So here's a summary of that. MYH9, yep. These usually don't metastasize. However, Krauss, of course, will tell you about the one case of USP6 rearranged nodular fasciitis that metastasized. Questions? All right, it's 9:03. Should I keep going or should I stop?
How many cases are we through? We still have like 5 slides, if I recall.
We have Yeah, we have a couple more. Oh yeah, only a couple more entities.
If we want to speed through them, that'd be great, because I was really stuck on these, so I'd be curious to hear.
We can do them pretty quickly, and then I'll share this presentation so you can go back and look at the slides. Okay, so circumscribed.
Yeah.
Okay.
Oh, sorry, you were
Myxoid.
listening.
Circumscribed, yes. Myxoid, yes. What else is in the background?
These are kind of distinctive fibrocollagenous bands.
Mm-hmm. Kind of some wavy bands.
Some of them just look weird. I don't really know what else to
Doesn't
say about
look
them.
weird. Yeah, we're gonna go back and look at that because that's crucial, and I think we need to pay more attention to those. But otherwise, we see myxoidy, we see wispy collagen,
Like alternating
and
bands of it.
yes, and then we see these weird things. Yeah, is this what you were talking about?
Yeah.
Yeah. What are those?
I am not sure. This looks like an element of muscle, frankly. They look like sarcomeric segments, frankly.
Okay, they're sort of segmented, but they're pretty. Does this look otherwise like muscle? Like, is it really eosinophilic? Does it have a muscly nuclei?
Eh.
They have a name but can't remember.
It's a tendon, right? Or tendinous insertion, maybe? Site?
So what do you see that wavy collagen with compressed nuclei in between for a tendon?
Elastin fibers?
No.
Elastin. All right, we have a few things. We have tendon, we have elastin, we have something that I can't remember. Okay, maybe once we figure out what this is, those will become clear. What nuclear shape are we dealing with here?
They are maybe kind of almost like focally corkscrewing.
Okay, so focally corkscrewing or wavy, right?
Wavy,
which
yeah.
implies
Nerve, I guess.
nerve. Okay, so we have pointy end here, wave here, right? I circled a nice wave here, pointy end. You really have to look closely, right? You really have to investigate a lot of cells because not every single one of them is going to give you the feature that says what it is, right? So like in that nodular fasciitis, so many of the cells were ovoid nuclei, open chromatin, small nucleoli, right? That was clear. You have to look, sometimes with nerve, you have to look around, right? So look around for those subtle features of wavy pointy. All right, so wavy pointy with myxoid and some wispy collagen in the background. Is anybody hungry?
Carrots.
Carrots. Okay, so this is technically what they're calling as shredded carrot collagen. Okay. So thank you for that. I don't see it, but there it is. So we have wavy nuclei, we have myxoid and carrot collagen, and we have a circumscribed thing in the background.
Is this a neurofibroma?
This is a neurofibroma, okay? So not only is it a neurofibroma, but it's in this sac, right? It's very, so it's either, it could be an intraneural neurofibroma.
Yeah.
The other thing that it could be is part of a
Plexiform
neurofibroma, okay, which is again these sacs or bags.
A bag of worms.
And here's a nerve. I didn't show you this before. Here's a nerve on the side, right? So where you are is always important. Look for those associated nerves. And so what was I trying to show you? What was I trying to show you in the neurofibroma? That if you see that, you're like, okay, I know exactly that I'm dealing with a nerve sheath tumor. What were those things I was pointing out to you?
Axons?
Yes, so these are axons with nodes of Ranvier. All right, so these little spaces, right, that jump along are where the myelin sheath comes and goes, right? So there, if you look carefully, you may see an axon down the middle of this, and you see these alternating areas of myelin, no myelin, okay? So, right, they kind of could be strappy or myoid, But you putting all things together with the nuclear features, with the wispy collagen, etc. These are nerve nodes of Ranvier. So how can we tell that they're not strap cells? So arguably, do these have nuclei? Do you see? Because if it's truly a strap or a rhabdomyoblast cell, it should be a cell that has a nucleus in it that has striations, right? So it doesn't really have that. It doesn't have a nucleus, and the striations aren't like even. They're like curved, right? Like these. So there's number one, there's a line through the middle of it, and the alternating bands are somewhat like cuppy, like that. So that's how I tell the difference a little bit. Does that help? And so if you look at a nerve cut on cross section, I'm sorry, I'm spending a little bit of time on this because I think we sometimes overlook these subtle features. Sometimes you can see axons cut in, this is blurry, I'm sorry. Next time we see a nerve, we'll try and look at the axons cut in cross section versus longitudinal section, right? So the nodes of Ranvier you usually see when they're cut in longitudinal section like that. So this should be S100 positive because those are spindly Schwann cells. It seems to perhaps be contained within a perineurial capsule. So we already talked about perineurium being, EMA, right? So they should have an EMA perineurial capsule. Here's just a breakdown of your various immunostains that you might want to throw on things. Oops. Okay. Oh, randomly I clicked on this. I don't know if you guys clicked ever on this little paper clip, but I've attached a file, which is a soft tissue with myxoid stroma review article. I think it's pretty good, so check it out. All right. This next one, these are all starting to kind of, you know, blend in our heads, but I think it's good to sort of see them consecutively. So, very wispy myxoid, wispy collagen, vessel, 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 vessel. This was a path presenter case. I didn't upload this one, so I can't be 100% sure of the differential on this, but the diagnosis that they were offering was, sorry, an angiomyxoma, an aggressive angiomyxoma. So I have a better example in my files that I can give you, but just so you guys know, a deep or aggressive angiomyxoma is one of these things that's usually in the pelvis perineum of females. That is exactly what it is. It's highly vascular. Usually the vessels are not delicate. Usually they're variable from delicate to thick-walled, as you can see here. Usually the stroma is quite myxoid and paucicellular. Usually they express hormone receptors. Usually they're highly infiltrative and hard to excise. So just know this. You probably get this in your gyne rotations, but sometimes there's some overlap, you know, between the gyne and the soft tissue. So just consider aggressive angiomyxoma. And then I put this last one here to remember our differential diagnosis of cutaneous myxoid lesions. So probably the best way to talk about these is in context of each other. So superficial angiomyxoma versus superficial acrofibromyxoma are the two main cutaneous ones that are going to be differentiated by essentially, do they have neutrophils and entrap skin adnexae, such as the superficial angiomyxoma? Do they not have neutrophils and not entrap adnexae and are associated with a nail, periungual, which would be superficial acrofibromyxoma. So you can kind of read these over to help out in your differential diagnosis between those superficial ones. I've put slides here for your review. I think this one on Path Presenter was called superficial angiomyxoma, which I guess if you look carefully, It does kind of surround this adnexal structure, which is a sebaceous unit. The only thing I couldn't really find were significant neutrophils, but that's what they, that's what they said it was. Okay. And then, does anybody want, this is my like fun bonus. We're in the thigh. Who wants to diagnose this? Myxoid,
Really?
yes.
Hmm.
Collagen, yes.
It's got an epithelial lining that is focally kind of looks almost like apocrine. Like, to be honest with you, when I looked at this, I thought we were dealing with like a cutaneous lesion, like a syringoma or something.
Okay.
Kind of got this reticular pattern to it.
Yep. We are, in this case, we are in the subcutis, but the thing you said, which is syringoma, is pretty much identical to this, but in the dermis.
Oh, so is that what is it called? Something mixed tumor?
So why do I put this on here? Because I love head and neck and I love bone and soft tissue. So what am I trying to tell you? Can I type? Yes. Okay. So chondroid syringoma, skin, benign mixed tumor, sort of deep soft tissue.
Okay.
And what am I thinking of in the head and neck that this looks exactly like?
We're not playing.
Pleomorphic adenoma.
Thank you. So all of these three things are pretty much the same, okay? So they are all circumscribed lesions. They all have a variably myxoid to chondroid background. They all have epithelial and myoepithelial cells in bilayered ducts, right? So the epithelial cells in the center, the myoepithelial cells at the periphery. Whether they are coming from a skin adnexal eccrine, site with eccrine differentiation, whether they're coming from a deep soft tissue site just from a mesenchymal stem cell, or whether they're coming from the salivary gland and creating a pleomorphic adenoma. These are all essentially histologically similar. They're called different things depending on where they come from, and they all have rearrangements of what gene?
It's HMG2 again, is it? Or PLAG, rather.
Flag?
So it's either, right? It's either PLAG, pleomorphic adenoma gene, or it's HMGA2. So don't get confused by the nomenclature, but be, mindful, of the morphology. So this is just an example of a deep soft tissue lesion that is a benign mixed tumor of soft tissue, okay? But it could be difficult if you got a core biopsy when you're dealing with myxoid stroma and some associated glands, but keep this in the back of your head. It's a rare tumor in the soft tissue, but it can occur. Yes, I see in the comment PLAG. Questions, comments, any other thoughts?
Not offhand. Thanks so much for hosting this. I thought the format worked really well, and being able to preview using Path Presenter was really, really slick.
Good. I will send you the link to this version with the PowerPoint slides. And I think you guys have Peter coming up next week. I think let me ask you this. What do you want me to do next in this kind of format?
I mean, if I were to think about the areas in bone and soft tissue pathology where I still personally feel weak, I think that more of a discussion of peripheral nerve sheath tumors might be kind of nice, and we could potentially ask Dr. Pytel to do a bit more of that. Like the neurofibroma just now that I didn't recognize, or soft tissue perineuromas or MPNSTs. I think a review of those would be very helpful. I mean, honestly,
years, do you have any specific areas you guys want to discuss, or for Imran or Kyle? No.
Yeah, I mean,
nothing specific. No, I mean,
More. I think given that this is also the end of an academic year, like more heavy on the slide review than on the didactic is good.
Good. So this ratio was okay then? Just a few slides?
Yeah,
Very solid.
I think so.
Yeah,
I mean,
the summary slides are super helpful.
And all of my full soft tissue PDFs are already in the M drive, so I don't feel the need to like
right.
do those.
To be honest, if you were to just keep doing sessions like this and just pick different different patterns, you know, you do myxoid, you do lipogenic, you do I don't know, things that like you just keep doing one of those each time, that would be perfect.
Okay, will do. And you may want to just ask Peter to do the nervy stuff, since he will give you a much more in-depth explanation than I can.
Okay, will do. Great, thank you.
Thank you, guys.
Great, thanks.
Take care, everyone.
Hey, Dr. Cipriani, before you go, do you have anything on Path Presenter, like just like a rapid fire review of soft tissue lesions, or do you know of any site that has a good comprehensive review?
So did you sign up for
the Path Presenter, the one that you sent out?
Yeah.
I did. I haven't done it yet.
Okay, so start there. I don't know that it's comprehensive, but so I'm going to stop the recording.